So now let's get right into the different skin lesions, their differential diagnosis, conditions associated with them, and the clinical features, diagnostic features, and management and treatment of these conditions. So we'll start from the top of the mind map, and the first thing was macule. So what is a macule? Macules are basically skin lesions that are different pigment from the surrounding skin. They are less than 1 centimeter and they are flat. So they can be hypopigmented, hyperpigmented, and erythematous. So what is the differential diagnosis for hypopigmented macules? So as you look at the mind map, on the very top, the macules are divided into these 3 different categories: hypopigmented, hyperpigmented, and erythematous. The hypopigmented macules differential diagnosis is going to be simple and easy: Tinea infections, vitiligo, and Pityriasis alba. So now we have quite a bit of information on tinea infection, and the rest two are going to be straightforward and simple and very quick. But we have quite a bit of detail on tinea infections because they are just so common and so different types. So tinea infections are basically caused by dermatophyte or fungus infections. Fungus is everywhere. We all have it. Nobody's free of fungus. It's a part of our environment. But when it becomes overwhelming and causes skin reaction, then we call it tinea infection. So the tinea infections, based upon what part of the body it is affecting us, we give it a different name. So it's as simple as that. And the risk factors are going to be humid and moist environment, perspiration, and underlying medical condition, for example, diabetes or any immune compromised condition. And the clinical features are going to be dry, scaly, slightly itchy, hypopigmented macules. So it's going to be macules, not other things. So it's going to be flat. There may be a little bit of scaling, but as we discussed earlier, scaling is usually a secondary skin lesion. So primarily these are going to be macules. So what are the different types of tinnias? Let's look at them. So tinea capitis is on the head, capitis. Tinea cruris is going to be in the groin area. Tinea facie is going to be on the face. Tinea corporis is going to be on the body. Tinea barbae is going to be on the beard area. So only men get it. Women can also get it. Tinea manuum is going to be on the hands, and tinea pedis is going to be on the feet. So again, tinea pedis is going to be on feet. Tinea unguum is going to be on the nails, or it's also called onychomycosis when it's involving the nail film. And then tinea versicolor is also called Pityriasis versicolor. Actually, that is the correct name because it is caused by malassezia, which is a normal skin flora in the form of the fungus. And then there is Majoshi granuloma. So Majoshi granuloma may show up here and there in different tests or exams. That is basically just persistent fungus infection of the hair follicles, and it shows like a granuloma, which means that it feels quite itchy, uncomfortable, and it's thickened, so or basically causes the thickening of the skin. So it is called Majoshi granuloma, and patients may get upset because it doesn't feel right, it doesn't look like a typical fungus infection, so you may actually misdiagnose it. But if you're familiar with it, if you know what Majoshi granuloma looks like, you can tell the patient, reassure the patient, give them the proper treatment, and just feel good about it. So diagnosis of tinea infections is made based upon the cutting edge technology. No, it is made by just simple exams. So looking at the patient and talking to the patient just for a few minutes, you can make the diagnosis very easily. And so that's how the diagnosis is made. You can use dermoscopy, you can use Wurtz lamp, and you can use KOH, preparation and biopsy and all this and that. But 99% of the time, that's not needed. How is the treatment done? We avoid the triggers. So avoid the moisture, the hygiene, the perspiration control, and then we can use the topical antifungals and the systemic antifungals, which are going to be your ketoconazole type of drugs and glycofulvin type of drugs. And we progressively intensify the treatment as the condition becomes more morbid. So vitiligo is basically an autoimmune condition because of the destruction of the pigment cells or melanocytes. They just fail to produce melanin. It's basically a genetic disorder where there is deficiency of the enzyme which codes for the melanin pigment called tyrosinase. So because of that, there is white color, or there is basically depigmentation of certain skin areas. And the treatment is really not necessary if it's very limited to small amount of the skin or small areas. But if it's extensive, you can definitely do depigmenting creams in areas that are spared. So you can do hydroquinone. This way the patient's color becomes uniform, because usually they are upset about the irregularity in the skin color, not necessarily because of the vitiligo hypopigmented color itself. And Pityriasis alba is another condition where there is low-grade inflammation in the skin and there is hypopigmentation. So it's not complete depigmentation. It's not because of the destruction of the melanocytes or because of the enzyme deficiency, which is genetic. It's just a condition where people just have less pigmentation. And it is usually a very benign condition. We don't know what the cause is, at least for now we don't know. And the treatment is just reassurance. Or you can do hydroquinone cream. So now we move into erythematous macules, or macules that are red appearing. And so this is another huge chunk of the part of the DSA. So there's lots of differential diagnosis. We'll go through all of them. So as you can see on this slide, there is a snapshot of the mind map that is just showing where we are in terms of our differential diagnosis and skin conditions. We are in the erythematous macule section. So there is multiple differential diagnoses, and as we move from from the top to the bottom in a clockwise fashion, the erythematous macules can be secondary to virus infections, and we'll go through all of those infections: the erythemas, the infectiosum, the multiforme exanthem. They can be because of drug-induced eruption, for example. Different drugs can cause it, and they lead to pretty serious conditions. For example, Stevens-Johnson syndrome, toxic epidermal necrolysis, which will be spelled out later in the DSA. They may be immune-mediated, for example, Kawasaki syndrome, COVID-19, and lupus. They may also be tick-borne infection, for example, Erythema Marginatum, migrans, which occurs as a result of tick infection, or tick-mediated infection. Then erythema Toxicum Neonatorum is a benign condition. We'll talk more about it later. And lastly, certain bacteria can cause erythematous macules. And a very popular such infection is erythema marginatum because of rheumatic fever, which is, by the way, not very common anymore. So tackling all these erythematous macules, the first we will discuss Kawasaki syndrome, because it's just so interesting. So Kawasaki syndrome is basically an autoimmune disorder where out of nowhere, we don't know what the cause is, patients will develop certain features. So this is going to occur in patients younger than 5 years of age typically, or pediatric age group generally speaking, and they will have at least 4 out of the 5 of these following features for at least 4 days. So that is a must thing that has to be present to make the diagnosis. So what are those 4 out of 5 features? Well, the patient should have fever, then they should have a rash on the skin or the face. They should have strawberry or red colored tongue, so there is mucous membrane involvement, there is tongue involvement. They should have conjunctival injection or conjunctival redness. They should also have the extremity change, for example, swelling, or including the erythema of the palms or the hands. And finally, there should be cervical lymphadenopathy. So out of these 5 things, 4 are present, and they've been present for at least 4 days, then we can say that this patient has Kawasaki syndrome. So you can actually make the diagnosis based upon clinical features. You don't have to do diagnostic testing because there is no specific diagnostic test available as such. So when people have these and patients come in with these symptoms, we make the diagnosis and start the treatment right away, because it's important to treat this condition very quickly. Otherwise, these patients can develop aortic aneurysms or other cardiac complications where we don't want them to become worse. So the treatment involves basically first doing the diagnosis and then doing the echocardiogram to make sure there is no complication. Aspirin is this is the only time when we give aspirin to children, because otherwise we don't. And aspirin is given in this condition because it helps with the inflammation. We can do intravenous immunoglobulins, which are necessary for the treatment. And then finally, newer treatments, for example, in the form of biologics, are also available. And then of course we do supportive treatment in the form of fluids and hydration and this and that. So this is multi-system inflammation or inflammatory syndrome in children secondary to COVID-19. So we just need to make sure we differentiate between this and Kawasaki syndrome. In COVID, there's going to be involvement of multiple systems. Hardly there is any system left not involved. The only one that I can think of is genitourinary system, and maybe that's because we don't know yet. But almost all the systems of the body are involved. There is fever, there is rash, there is cardiorespiratory system involvement in the form of cough, shortness of breath, a sore throat. There is gut involvement, there is nausea, vomiting, diarrhea, and this and that. There is thrombophlebitis, so there is COVID dose, there is small blood clots. There is central nervous system involvement, for example, brain fog and lethargy, altered mental status. And finally, in the labs, we see elevated ESR, elevated CRP, elevated fibrinogen levels, elevated dimers. We also see additional markers of inflammation. Troponins may be elevated because of cardiac involvement. And finally, there may be an abnormal echocardiogram. So there is a lot of things that can happen in COVID-19 in children, in adults also, but this is basically specifically for multi-system inflammatory syndrome in children because of COVID infection. And we can differentiate between this and Kawasaki or other problems based upon the clinical scenario. So SLE or systemic lupus erythematosus is a condition that involves multiple systems and causes multiple symptoms. So this is a widespread condition and it's an autoimmune disorder. We don't know the exact cause, but we know that multiple factors are involved. So there is gene-environment interaction. These patients are genetically predisposed to this condition, and when the environment interacts in the form of different triggers, stress, just basic stress of life, infections, or or dietary factors, people basically just start to show symptoms. So in this condition, in the prototypical form, there is a butterfly rash, and when you see the butterfly rash, you say, aha, this could be lupus, but it's not always present. So that's something to keep in mind. And there can be blanching rash in the extremities, there may be cold intolerance, quote-unquote Raynaud's phenomena. There may be other things present also as far as the skin is concerned. In order to make the diagnosis, multiple characteristic features have to be present, and based upon American College of Rheumatology, at least 4 out of 11 things that they present to us have to be present. So based upon American College of Rheumatology, we have this criteria to establish the diagnosis of lupus. So on the left hand side, you have this long table from up to date. So we don't have to look at that necessarily, although you can if you want. On the right side, there is the diagnostic criteria in a nutshell. So we can look at all of those 11 things, and if you have 4 out of those 11 things, then we can give that diagnosis to the patient. So what are those? That is basically the biggest thing is the skin involvement. So the photosensitivity, the butterfly rash, the mucous membrane involvement. Then the next thing would be the arthritis or serositis, or basically joint pain or aches. Then there is hematological problems, there is neurological problems, there is nephrogenic problems, so kidney involvement. And then lastly, there is lab findings, which are in the form of ANA or antinuclear antibody positivity. And then of course there is immune mediated markers, which are going to be your double-stranded DNA, anti-Smith antibody. So when it comes to management of patients with lupus, and this topic is perhaps covered in other parts of the curriculum as well, the goal of the treatment is symptom management, quality of life improvement, prevention of further damage, and patient education, and making sure that overall quality of life is improved. So we can do it in the form of lifestyle management and also in the form of pharmacological treatments. So when it comes to pharmacological treatments, we have immune modulators, which are basically hydroxychloroquine. We have immune suppressive treatments available, which are basically prednisone or steroids, methotrexate, mycophenolate, and then lastly we have biologics available, which are the new kids on the block. We have rituximab, we have others, and those are very effective these days, and we can tremendously improve the quality of life for these patients when we implement all of these things in addition to lifestyle modification, which is going to be control of exacerbating factors or triggers, which are most of the time going to be stress, secondary infections, diet, exercise, and other lifestyle related things. So this is Erythema Infectiosum, or fifth disease. So this is a very interesting thing where patients have a rash which is in the form of a slap cheek appearance. So this is caused by the the parvovirus B19 or the fifth disease. So you can remember all these words. Basically, in the end, it means the same thing, which means that the patient is going to present with a rash as if somebody slapped on their cheeks. It's going to be a young patient, and the patient is going to look very fine otherwise. So there's not going to be any major complication because it's a very benign self-limiting condition most of the time. Sometimes parvovirus B19 can lead to pure red cell aplasia. So you'll read about that later in the curriculum, I think. But as long as that complication is not present, it's going to limit itself and it's going to resolve spontaneously. And you just need to remember that it is associated with parvovirus B19. There may be a lacy rash rest of the body also, but when you see a slap cheek appearance, that's parvovirus B19. Erythema multiforme, as the name suggests, occurs as a result of multiple things. So it can be a virus, for example, herpes simplex virus. It could be mycoplasma. It could be drugs. So basically, there's going to be target lesions that may appear in the form of red color. There may be some crustiness involved. So there's going to be different patterns or different morphologies of these lesions. But basically, it's going to be erythema multiforme as a result of an infection or drugs. And usually these are going to be benign, self-limiting rashes. So now we get into more serious conditions that cause erythema. So two of those are going to be Stevens-Johnson syndrome and toxic epidermal necrolysis. So this is a condition where patients, as a result of either a virus infection or another trigger that causes an immune-mediated reaction throughout the body, involves skin and the mucous membranes in the form of involvement of the oral mucosa or genital mucosa or other mucous membranes. Patients are going to present with marked erythema of the skin. So there's going to be erythematous macules. There's going to be fever most of the time, and the patients are going to look pretty sick. Stevens-Johnson syndrome and toxic epidermal necrolysis are going to be basically two parts of the same spectrum, where Stevens-Johnson syndrome is a little bit less severe, and as it progresses, it develops into toxic epidermal necrolysis. So generally speaking, people say if there is less than 10% of the body involved, then it's Stevens-Johnson syndrome. If it's more than 10%, it's toxic epidermal necrolysis. But there may be some overlap too, but you can just remember 10% or so. The hallmark of the feature of toxic epidermal necrolysis is that there is going to be Nikolsky's sign, which means that there is going to be detachment between epidermis and dermis. It's a feature that is seen in pemphigus vulgaris as well. So whenever that is present, then you say, okay, we are in trouble, because these are the patients who are going to look very sick. Now there is acantholysis, there is separation between epidermis and dermis, and these patients are going to be very unstable, at risk for further skin infection, exfoliation, dehydration, and complications. They need a lot of support. So whenever you see these patients, you need to recognize it immediately and of course provide supportive treatment and of course treatment to prevent complications. And these images on the slide show basically, starting on the top, this is basically Stevens-Johnson syndrome, where there is redness of the skin, then there is mucous membrane involvement, there is involvement of the conjunctiva. Then on the bottom slides, there is toxic epidermal necrolysis, where there is just necrolysis of the skin. So it's self-evident that this condition is going to be pretty life-threatening. So what is the etiology and risk factors? Like I said, infections can cause it. Sometimes the virus infections with Mycoplasma pneumonia can lead to it, not necessarily directly cause it. Drugs are the major culprits. So NSAID, sulfur drugs, lamotrigine, which is an anti-epileptic drug. Some of the drugs are notorious for leading to this condition, although it is an immune-mediated possibly condition. So whenever a patient gives a history that they took a medication and then they started to develop this rash, then we should take immediate notice of it. The risk factors are going to be all those patients who are immunocompromised already to begin with, and of course these patients are going to have a genetic predisposition to develop this condition. So if somebody develops it once, then you always want to be on the lookout for getting it again, because these people have HLA mediated predisposition. So they have the HLA type in their genes already, which makes them puts them at risk. The treatment, again, like I said, is going to be supportive fluids, identify the lesion or the condition, and then provide all kinds of support and prevent complications. Erythema marginatum is going to be a pink or faint rash that just is non-pruritic and just kind of gradually expands on the extremities, and it extends centrifugally. So it's very, very slow, very, very sneaky, very mild. People sometimes don't even notice it, and it's usually a part of rheumatic fever. So people usually have other more obvious symptoms in the rheumatic fever where they may not even bring up the rash, but when you examine them, you look at it and you say, oh, this is erythema marginatum. Now, what are some of the other things? Let's talk about that. So once you've seen erythema marginatum, or even if you haven't seen erythema marginatum rash, but you're suspecting rheumatic fever, which basically occurs as a result of group A streptococcal infection of the throat or pharyngitis, and you're thinking, oh gee, maybe this patient has got rheumatic fever, because now see there is a rash too. You need to fulfill the criteria, which is Jones criteria. So there's got to be at least 1 from the major and 2 from the minor, or 2 major. So what are the major? Well, there's got to be a migratory arthritis. So there's going to be pain in different joints of the body, not just arthralgia, which is pain, but arthritis, which means there should be signs of inflammation in the large joints. There should be carditis, so there should be some type of involvement of the heart, so you should be able to elicit it. There should be central nervous system involvement, so Sydenham chorea, which is basically abnormal movements of different parts of the body or joints of the body. So these are 3 systemic things that one of them can be present. Erythema marginatum is also a part of the major criteria. And then there is subcutaneous nodules, which are small nodules under the skin. So if any of these 5 is present and 2 minor are present, then we can say it's rheumatic fever. Or any 2 of these 5 are present, we can say it is rheumatic fever. Now, what is the minor criteria, or the features included in the minor criteria? Well, that's arthralgia, which is just simple pain, not inflammation. So there's no stiffness, there's no swelling of the joint, and there's no other markers of inflammation, just simple pain. And then fever is a part of the minor criteria, and remember, fever is more than 100.4. If it's less than that in fever, then there is elevated CRP or ESR, which are markers of inflammation. If they are present, we include them in the minor criteria. And lastly, if there is prolongation of the PR interval, can happen sometimes on the EKG. So if that's there, then we call it a minor criteria feature, and the patient has met it. Now, if 1 of the major and 2 of the minor present, that's rheumatic fever. So whenever you're suspecting it, it's important to establish the diagnosis, because treatment is the key. So patients with rheumatic fever, we need to treat them. Why? Because we need to prevent complications, especially the cardiac complications. So we treat them with penicillins, and of course, as you can see, that we should do the oral penicillin for 10 days, or do the IV or IM penicillin or intramuscular penicillin, 1 single dose, or until age 21. These days, we don't necessarily see this very much, so this condition is not very common. But in the old days, we used to see it quite a bit, and people would develop cardiac complications from rheumatic fever, murmurs, mitral valve stenosis, and regurgitation, and this and that. And it used to be a big deal, but now it's becoming more and more rare, thankfully. Erythema migrans or Lyme disease or the erythema associated with Lyme disease is very interesting. So what happens is this occurs as a result of a tick bite. So the tick bites the human beings or the patient, and then as a result of that, there is this spirochete infection that sets in. Patients develop a rash within a few days, usually within a few days to a few weeks, and the rash spreads centrifugally. So it is kind of from a small tick bite, it enlarges, and the picture is right there, and then it becomes an erythema. And there is central clearing of the rash. It can become as big as 20 centimeters, so it can become very big, but then in some situations the rash may be absent altogether. So it means that the absence of rash does not preclude from the diagnosis of Lyme disease. Patients have additional symptoms. For example, they may have arthralgias, loss of appetite, joint aches and pains or arthralgias, and they may also have low-grade fever. So they may feel very tired also, and they come in and they see you and they give you a travel history, camping history, outdoor activities, and sometimes every now and then they'll say they were bit by a tick. So when you put all of those things together, you can think about Lyme disease and draw the titers. These days we use Western blot, which is a diagnostic test, which is very quite specific. And when we do the test, we can make the diagnosis based upon how many bands of immune-mediated proteins we are seeing. And then finally, the treatment is going to be doxycycline or amoxicillin and supportive treatment. Erythema Toxicum Neonatorum is another very interesting thing, where the name of the condition is very interesting. It sounds like maybe there is something big associated with it. Maybe it's a big deal, but actually it's nothing. It's just macular erythematous papillary rash or lesions that show up on the skin in a newborn or an infant and are distributed widely, and the moms usually or the parents are concerned about it, and rightfully so, because they just look very different. But the child is going to be happy, healthy, eating and sleeping just right. So there's no other symptom, and when you see that there's no fever, there's normal hydration, then you can just basically reassure the parent and say it is Erythema Toxicum Neonatorum, and when you give that name and reassurance to the parents, they are usually just fine, and this will resolve itself on its own. Necrotizing soft tissue infections are life-threatening conditions where there may be involvement of skin, fascia, and muscle. And whenever these occur, these place the patients at risk for rapid complications, and we need to recognize these conditions very quickly so we can stabilize the patients. The etiology of this condition is going to be polymicrobial or Clostridium. So Clostridium is a bacteria that can cause this infection, usually as a result of penetrating wound, or there is an interruption in the skin barrier, and somehow these microorganisms get a hold of the tissue and they start rapid involvement of the surrounding tissues, and people become very sick very fast. There is erythema, there is crepitus because of the gas production and then there is bullae. So these people will show these rashes and skin lesions very fast. Subtypes of these lesions are going to be necrotizing cellulitis, which is basically involvement of the skin only. So that's a little bit less severe. Then there is necrotizing fasciitis, which is involvement of the underlying fascia or soft tissue, which is going to show the crepitus and the bullae. Necrotizing cellulitis may just be the redness or maybe bullae too. And then there is necrotizing myositis, which is basically the dead end condition. That is where the muscle is involved, there is gas produced there, and there's a whole lot of complications, and these patients will definitely need surgical treatment and debridement, and oftentimes they lose a lot of tissue. So the treatment is going to be broad spectrum IV antibiotics, hospitalization, hydration, supportive treatment, and surgical debridement. It's very important to treat it.